discussing today is really about, to begin with, about what happens to the human brain as we age. You know, what sort of changes are you facing, even without discussing any type of cognitive impairment, well, what's occurring, that you should be aware of that sort of will affect the person's ability to drive safely. One of the first things is that the brain undergoes shrinkage or atrophy as part of the normal aging process. The brain that you had when you were in your 20s going to college and that is not the same brain that one has when they're in their 60s or 70s. There is a slow but gradual loss of mass of the brain, the volume of the brain over time. There's been various estimates between 0.1 and 0.5% per year. This is far different than a person that's developing Alzheimer's disease, where sometimes we can see a loss of volume or shrinkage of the brain, or atrophy as we call, 5 to 10% per year. So there can be a very dramatic shift in volume. But there is this shrinkage, and even if you're looking at, with me, let's say you're in my clinic and we're looking at a radiology report, the radiologist might report there's normal volume loss consistent with aging. So we're all aware of this. Different areas have different areas of loss. And I'm sorry if I can't point over there, but anyways, okay. All right. It's there? I see it on my hand, but you guys see it anywhere here? Okay. Never mind. Okay, you follow along. But on the top line there, it says like in 3 areas, neocortex, cerebellum, and hippocampus. So why are those areas more susceptible to volume loss? Well, these are areas that are very oxygen dependent. These are areas that when we have someone that has a hypoxic injury in the hospital, let's say they had a heart attack, they're not getting enough oxygen to the brain, these are areas that will be damaged first, because they're the most sensitive to oxygen loss, with the hippocampus being very important for, in general, memory, and that specifically short-term memory over the last 12 months. And there's other changes in the brain overall, but I think the major thing is this loss of neurons as part of the normal aging process. And then there's changes in, well, we're really not going to worry about sense of smell or olfaction, but I would point to you vision. And there's 2 areas that we should be concerned about. As we get older, we lose our ability to sense in the blue color spectrum. You know, you see everything that you're seeing today in the spectrum, from like hot yellow or white all the way down to blue or black. People will lose the ability to see in the lower color spectrum, the blue spectrum, and then this contributes to inability to drive at night. They're not able to see as well at night because of this. And you probably maybe have friends or yourselves have decided, well, I really don't feel comfortable anymore driving at night, and this is one of the reasons. Another reason is that the cornea and also the lens of the eye, which gets filmed up by cataracts, but also the cornea, that surface of the eye where you put like contacts, over time becomes damaged, and it's no longer clear, becomes very milky sometimes. You cannot really perceive it if you're looking in a mirror, but we can perceive it sometimes, and definitely this is affecting light going into the eyes. And what's happening is the light's becoming refracted. It's, instead of going straight back to the retina, it's now breaking up, and it's not going to where it should go. And again, this could be affecting driving. So then we have trouble with looking up, looking down, with impaired upgaze specifically. Loss of hearing, well, you know, with sirens and whatnot, that could be of concern. You have diminished power in the motor system, specifically in the proximal lower muscles, those thigh muscles. These are the muscles that take you up and down stairs, in and out of cars, in and out of chairs, that if you become weak, you have difficulty here. One of the problems is that if you lose power there, then that will prolong your response time if you need to hit the brake or the gas pedal, because power is diminished, and therefore it might take you longer to get that correct power into that brake pedal to induce a stop. Diminished muscle bulk, really in the hand muscles, and also overall increased reaction time. What will happen is there's slowed processing speed. We even have a term for it, we call it bradophrenia, which is slowed processing speed. It takes you longer to understand information and to react to it accordingly. This is very important when driving. And this is where the problems might occur when we have patients who will say, well, you know, I drive okay, I'm just driving on local streets, and I'm doing fairly well. Well, and they're driving a very well-defined route that they're very familiar. What we get concerned about as neurologists and physicians in that is not that, but it's what happens when you're faced with an emergency. What happens when you have to do that split-second decision and maybe avoid someone running out between cars, avoid a car suddenly coming at you. And this slowed processing speed that we're faced with may affect your ability to respond appropriately. Also, too, you lose sensation, and it's quite classical. Anyone over 65 will have loss of vibratory sense below the ankles, and we almost expect to see that in someone in that age. And actually, when we do bedside testing, but if they do more quantitative testing, like in an EMG nerve conduction study lab, you actually find that the loss of sensation is actually more diffuse than what you would see at the bedside. Why is this important? Well, if you know someone that has diabetic neuropathy, what the problem is that sometimes they can't feel gas or brake pedals. It's so severe. These people cannot distinguish between walking on a tile floor and walking onto a carpet. You know, you'll feel the tile, nice, smooth, cold, rug, very rough. These people can no longer sense that. So what it is that the information that when they apply gas or brake, and it's sort of like going back up to the brain to sense that, they're not really sensing it well, so they can overshoot. They might feel that they're really not pushing on the gas, so they really push on the gas, and then if they're in a confined space like a parking lot, the car shoots forward. Or they might hit the brake, and they don't feel that they're stopping well, so then they really apply pressure, and suddenly they're stopping, and they might get rear-ended. Also, too, gait and balance, may affect, because what you're doing is you're talking really about joint movements, how well the legs and the arms are working in synergy. You know, it's not just isolated systems. They're all working together, like your legs from the hips down, arms from the shoulders to the hands are working in unison to perform a task. And this could also be affected. And now finally, there's cognitive findings in normal aging. And of course, what it is that we always are looking at this and looking at various areas that what could be affected. One of the things that are available or is affected is short-term memory. And this begins to decline at age 60. A good example is I was telling you before about that hippocampus that's very oxygen sensitive and might undergo cell loss. Well, this is where short-term memories are stored in that structure for the first 12 months. Working memory is you're using this to solve problems and you're manipulating information. And this also undergoes change, and this might contribute to that slow processing speed that we discussed earlier. And then there's other memory types that we're just going to skip over right now. And again, the speed of mental processing. And then language. Well, language really isn't an issue with driving unless you have severe vision loss in combination with maybe inability to speak or read well. And then trying to identify street signs, etc., might be more difficult for you. So, let's see. So what sort of cognitive domains are we concerned about when a person drives? Well, what we're concerned about, one is executive function. So what's that? Executive function is used in various areas of thinking. It's in the frontal lobes, the front of the brain. It's used for decision making. It's used for processing information. It's used for planning. So therefore, it's very important for that to be working well in order to have appropriate driving skills. Memory, very important for having understanding of perhaps routes and maybe alterations of routes. You know, a lot of times we'll have people that'll say, well, I can drive really well between, you know, my house and the grocery store, the house and the market. And then we might get reports from the family that they are doing major construction and suddenly that person has to drive new routes and they're getting lost because their long-term memory is not able to compensate because they don't have that route well fixated in their brain. Also, too, again, visual spatial, that can also be of concern. And what is this? Well, visual spatial in regards to driving is that you have in your brain, if your brain is looking at a map, the brain is actually dividing that into grids. And the grids, then you put information in it. So you will probably put information, if you're one that uses, you know, various street signs and all that, you'll put in the various roads. If you happen to be from New York City, well, you'll go by, you know, stores and all that. And if you're in New York, you'll get directions like, well, travel up 3 blocks this way till you see Bernie's Deli, and then you make a left-hand turn past Bernie's, and you go a couple more blocks and you'll see Al's gasoline station, and you make a right past Al. So these people are still able to navigate in their environment, but they're using different sets of coordinates. So how does the brain normally function? Well, we're receiving information from the environment, what we see, what we smell, what we feel, what we taste, what we touch. And then we call up memories to interpret what we're seeing, what we're smelling, etc. So going back to the driving, you know, you're interpreting your surroundings. You're looking at those landmarks, or you're looking at the street signs. And so what happens with the brain, if you start having memory problems and pieces start becoming missing, that's when problems will occur with driving. You know, they might be able to go from point A to B, but they need to get now from point B to C, and that part's missing, and that's when they start getting lost or confused. So then if you have all the appropriate information, and you understand it, and you can relate to it, you can make the appropriate decisions. However, if you don't have all the information is missing, that's where problems will ensue. So the thing is, when people come see me, yes, I'm a neurologist and that, we deal with 2 diagnoses. And the first one is dementia. And I still get patients coming in that they fear that I'm going to put them in a crazy home or something, as terms have been used, or some type of home, lock the doors and throw away the keys because they may have dementia. Dementia is really a clinical diagnosis. It's nothing to be afraid of, but you have to understand it because it has very specific parameters. What we want to see is a person that has problems with memory in another area. It could be language, could be attention, it could be visual spatial. It can even be behavior. Someone that's severely depressed can also be included as that second component. And then the other one is that it progresses over time. And the third is that the person loses their ability to function independently. And this is the most critical aspect. So when we're dealing with retired patients, what we're looking at is the most complex activities you may be facing, which will be like finances, will be home maintenance, will be shopping and cooking, and will be driving. And this is what we sort of focus on to understand their abilities to function independently. And this is why we're also having the spouse or a family member or a friend there to interview them to see what they're telling us is correct and what's being observed. The other one is mild cognitive impairment. This is a relatively, I would say, new diagnosis. It's been around for a while in various forms, but really came to the forefront in the late 1990s. And what this is that there's changes in cognition, but the person can still function independently. So the thing is that you have to understand with the brain, there's like decline with normal aging, followed by perhaps the person going into a mild cognitive impairment. They may notice these changes, but they may not, because these changes may be so subtle that they're unaware of it. But this is when the family might be visiting after 6 months, comes and sees this person and realize there's a dramatic change. And then when memory loss predominates, they use this term amnestic MCI. And what's concerning with this, if we see a very prominent amnestic MCI, they have a risk of about 15% in developing Alzheimer's disease. Unfortunately for all of you here, when we talk about risk factors, the greatest risk factor by far is age. I hate to tell you this. I apologize ahead of time. It's unfortunate because, you've done the appropriate health regime, the appropriate cognitive stimulation regime, like being active, coming to lectures like this, trying to keep things stimulated and trying to keep active, but yet as we get older, age becomes the biggest risk factor. So when you're 65, the risk factor is about 1 out of 10 people will develop dementia over time. By the time you hit age 75, it's 1 out of 5 people will develop dementia. And by the time you hit age 85, the risk factor increases nearly to 50%, or 1 out of 2. So age becomes the biggest risk factor that we have to deal with. And that is something you should be aware of, because the way to perhaps minimize these changes is to continue to do, to the best of your ability, what you're doing today. To be stimulated cognitively, to socialize, because that's very important, to keep yourself physically and mentally active. So when we have cognitive decline, again, there is this in the lower right-hand corner, there's what a neurologist will be dealing with. Causes of dementia, 80 to 90% are the 4 major types listed there: Alzheimer's disease, vascular, Lewy body, and frontal temporal. But as you can see, we have a lot of other issues that we have to work on to really understand what is causing the cognitive decline and what we need to rule out. So that's why when I'm seeing someone and doing an evaluation, I will spend like 1.5 hours with the person initially and their family, which I know a lot of people are very surprised I'm spending all this time with them, but I have to sort of go through this, understand their problems, cognitively understand activities of daily life, understand depression, understand sleep, all of which can affect cognition, and at the end of the day, all could affect driving. If you're very sleepy, you're sleep deprived, that will probably reduce response time further. If you're very depressed, depression can cause changes in short-term memory, attention, concentration, and executive functions, which you need for driving. So all of those things are coming into play now when we're evaluating someone for this diagnosis of either cognitive impairment or dementia, which will therefore lead on whether they should continue to drive or not. And this is just a breakdown showing to you by far the greatest disease process that we have is Alzheimer's disease. And this is just the pathology. I'm going to skip over this. So what are the risk factors? Like we discussed, age, cognitive impairment, genetic markers can also increase risk. Family history, there's a first-degree relative. If you have a parent that had Alzheimer's disease, which could increase your risk, depending on what papers you read, anywhere from 4 to 10-fold. Vascular risks, these used to be called stroke risk factors, but you need to address them. Diabetes, hypertension, hyperlipidemia, tobacco use, alcohol use if it's excessive, low education or lack of physical and social activity. There was a study in Sweden, and what they looked at, because they have a socialized health system, they follow people between the time that they're born and the time that they die. Medical records are complete on these people. And of course, Sweden, a very cold country, a lot of social isolation, especially in small villages. And what they found is that the people that were more socially isolated had further volume loss in their brains, had further changes in the hippocampus, which is important for memory, than those that were socially active. So even socialization here could be a protective factor that could improve your thinking or maintain it, and again, would help you be able to continue to drive. Finally, there's nothing we can do about this. Risk factor is Alzheimer's disease is seen more in females than males. As a male, I apologize to all the women in the group, So as the brain ages, what we can see is that first it starts in the lower left-hand corner. This is where the hippocampus resides, but gradually the degeneration, the shrinkage is widespread. And so what are some of the clinical features when we're faced with someone with Alzheimer's disease? I'm using this as the typical dementia that we would see, or what we're faced in society in general. And usually you see poor short-term memory and loss of orientation. That's dealing with time and dates, place. Usually a smooth or slow decline without short-term fluctuations. And then other domains involved with time, such as language, visual spatial abilities, attention. There is, in fact, now 4 variations of Alzheimer's disease. Alzheimer's disease is not all memory loss. You can have a frontal variant, which is more behavioral dominant. These are people that might become very aggressive to the spouse. This will again reflect in driving because they become very aggressive while driving. They have disinhibition. The second variant would be language. They develop aphasia, what we call language disorder of speech, which may affect their ability to read signs properly, etc. The third one is the classical Alzheimer's disease, which is memory dominant. And the fourth one is in the back of the brain, which affects vision. We call this posterior cortical atrophy. And vision changes, which again could be concerning when driving. So, and what's interesting is like people that have the visual variant, their memory will be very good. If they come into the clinic and see me, they can memorize the 3 words, what we do in the testing. They can do other aspects. But when you have them do a task, a simple task like, let's say, fill out an envelope that you're going to mail, they can't do that. Or what they'll do is they'll put all the information that goes on an envelope, and so in the proper locations, everything is squeezed in one corner because they can't appreciate visually where things should go. Also, too, again, what we need to do is look at other possibilities that could affect thinking, and again, which in turn could affect driving abilities. Depression and anxiety I discussed about. Irritability, hostility, indifference, or apathy. Delusions, hallucinations, which we really don't see in the beginning of Alzheimer's disease. We see that in later aspects of the disease. If you have someone that's having hallucinations and delusions early on in the change of their thinking, we're probably dealing with more of a dementia with Lewy body. Sleep-wake changes, chronic insomnia. as we get older, by the time we hit age 65, 60% of all elderly people have at least one type of sleep disorder. So the most common one being insomnia. A high percentage of people will have sleep apnea. Again, these are things that can affect a person's cognition during daytime hours. You might think that sleep apnea should happen only to people that are morbidly obese. It doesn't work that way anymore. Sleep apnea can occur with someone that has either a very short neck or a very narrow neck, where the architecture of the trachea in that is very narrow, so they can have blockage very easily. So this whole concept of you must be like in Charles Dickens, I think it was Charles Dickens, the Mr. Pickwickian or Mr. Pickwick, that was this very run-ton gentleman who was constantly falling asleep, no longer really applies. And so if you do have a sleep disorder like sleep apnea or insomnia, you need to bring this to the attention of the doctors that are treating you in order to have good sleep, which will improve cognition. Well, one of the things is that the way we've designed cities in the United States are really designed for cars and not for pedestrians. It's unfortunate. I grew up in Detroit, so car capital of the world. But one thing you don't know about Detroit, there was Woodward Avenue that went all the way from the river all the way to about 12 to 14 miles. It has this very broad boulevard. Up to the end of World War II, there were streetcars that would go all the way. So my parents lived in the suburbs and would hop on a streetcar and take them all the way to downtown. Then someone came up with a great idea, well, we'll pave that over and put trees there because everyone should buy a car because you're working in Detroit. Which, okay, fine, but then as we get older, we're more attuned to the need of public transportation, and it's less and less available. And that's one of the problems that occurs when families come to our clinic and we're talking about driving, is the person has this fear of losing their driving ability, because they do realize in order for them to drive around their local city or visit family and that, they're highly dependent on cars. And so who drives and who has problems? Well, in the Women's Health Initiative Memory Study Epidemiology of Cognitive Health Outcomes reported that 60% of women had MCI and 40% of women who had dementia were still driving. So they're putting themselves at risk of getting in an accident and other complications. So the thing is, what we see is that when the person develops this, they're at increased risk of having accidents. There's no formal mechanism here in the United States or even in Europe or Asia that we can use to, limit people that have significant problems with thinking and should not be driving. When I was in California, what California did, which was probably the best system, was that we didn't make the decision. The family didn't make the decision. The decision was made by the DMV because it was actually a state law that if any physician or health provider or family member could formally present to the DMV a request for evaluation. And it was up to the DMV to evaluate that person, how they see fit, and make a decision. But this still created problems because I had patients that we would send to the DMV, and unfortunately the DMV decided that you could challenge the DMV, and they never made a decision on how many times. So I would send them to the DMV. The DMV officer said, no, you can't drive. And then they would see a second neurologist, and the second neurologist might agree and say, yes, you can drive. They go back to the DMV. And the DMV person would say no, and it's usually a police officer or a sheriff, and say, no, you still can't drive. So then they would go to the third neurologist. And they would just keep on doctor shopping till they got either enough doctors to agree where the evidence was like maybe 3-2 that for them to continue driving, and then they would get their license back. So there were still ways to get out of it. Unfortunately, where we worked, we had a higher standard, so we would also be sent people, and we were the bad cops, because the primary care physician who should have reported the patient would in fact send him to us for us to report to the DMV. It was very upsetting to the family and all this because they weren't not for a neurological evaluation, it was for a driving evaluation because they knew we would report the person if we had concerns. And, and it was sort of unfortunate that all this was being done in regards to driving. So I'm going to stop here, and, if there's any additional questions, I'll be back at about 11:20 and to answer those questions. But thank you for your attention, and I hope you enjoy the rest of the program.